Welcome to the podcast for Healing Neurology, where we talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine. And we have with us today Dr. Linda Bluestein, MD. She is a former ballet dancer and current integrative medicine physician and board-certified anesthesiologist. Dr. Linda Bluestein specializes in treating dancers and other athletes at increased risk of hypermobility disorders and is the founder and host of the podcast Bendy Bodies with Hypermobility MD. Dr. Bluestein also founded and is a former co-host of the podcast Hypermobility Happy Hour, the first podcast to focus exclusively on issues related to hypermobility disorders, and is a contributing author for the book Disjointed, Navigating the Diagnosis and Management of Hypermobile Ehler-Danlos Syndrome and Hypermobility Spectrum Disorders. Through her private practice, Wisconsin integrative pain specialist, Dr. Bluestein has helped people from all over the country live better lives. As a leading specialist in connective tissue disorders such as Ehler-Danlos Syndromes, EDS, she helped to create the first EDS CME, continuing medical education online program. Dr. Bluestein, a highly sought-after international and invited speaker, is at the forefront of research on pain, hypermobility, and dance medicine. She completed her anesthesiology residency at the Mayo Graduate School of Medicine after receiving her medical degree from the University of California, Los Angeles School of Medicine, and is a member of the International Association for Dance Medicine and Science, the Performing Arts Medicine Association, and the Resources Committee for the Dance Healthy Alliance of Canada. She has written and lectured extensively on the topics of pain, neuroscience, chronic pain, and hypermobility disorders. Dr. Bluestein is a member of the clinical faculty at the Medical College of Wisconsin, Central Wisconsin, where she also serves as the course director for the Rishi Healers Arts Program. More information about Dr. Bluestein can be found at her website, www.hypermobilitymd.com. Dr. Bluestein, welcome. Welcome to the program.
Hello. Thank you so much for having me.
There is a lot of ground to cover today. Certainly your emphasis has really been settled in hypermobility. So let's start there. What is hypermobility? What does that mean?
So hypermobility simply means that a joint has a greater than average range of motion. And that's all that it means. It's a descriptor, not a diagnosis, when we just say hypermobility.
And when we talk about hypermobility, certainly what we see essentially are the bones moving at a greater angle than is common. But what are all the tissues that allow for hypermobility to happen?
So the range of motion for a joint, so a joint can be hypomobile also, which is where it has less than the average range of motion. Joint range of motion is dependent on a whole bunch of different variables, including age, gender, previous injuries, surgeries, strength of the connective tissue, temperature, and some genetic factors as well. So there's a lot of different variables that go into whether or not a joint has normal range of motion or is it somewhere high or low on the spectrum.
Can you talk a little bit about the connective tissues that hold our joints in place, that kind of govern? What are the actual tissues that govern our range of motion?
So ligaments are what connect bone to bone, and those really don't have stretch. Those are much more static. Tendons connect bone to muscle, and then we have muscles obviously in between that when they shorten, they cause joints to move. So we actually have connective tissue, though, in many other places in the body. So lots of times people will think about connective tissue being a musculoskeletal thing. And while we do have connective tissue in all of those areas that I just mentioned, we also have connective tissue distributed all throughout the body. We have connective tissue distributed in all the various different organs, like our intestinal tract and in our skin and the lining of our gut mucosa. It's basically everywhere. So when people have a connective tissue disorder, part of what's confusing is that although oftentimes the musculoskeletal symptoms are what predominate, people will present with symptoms all throughout the body. And that's where they often end up getting labeled as being psychosomatic or something like that, because they have so many different complaints that oftentimes the provider that's listening to all of this thinks, well, that couldn't possibly be true. Therefore, this person must be making some of this up, or at least there's a lot of confounding variables.
And one of the things that we talk about is that although we can see joint hypermobility as one influence, if we suspect a connective tissue disorder, either congenital or acquired, then we can see problems, as you said, in the gut, problems in the nervous system like dysautonomia, problems in the immune system like mast cell activation. What are some other examples?
So some of the other really common things that we see are constipation is a really huge one. Because of the contributor of the connective tissue in the gut, we can actually have problems with bowel distension and evacuation of the bowels. So not everyone has constipation, of course, but that is a very common complaint that people will experience. And later on, they can start to also experience other things like gastroesophageal reflux disease. They might have gastroparesis, which is where the food moves more slowly through the stomach and the upper part of the digestive tract. So gastrointestinal complaints are a very, very common problem with these disorders. The other thing that we will often see is that their tissues won't heal as well. So for example, you'll see abnormal scarring. And so when you look at a person's skin, instead of seeing a nice, narrow scar, you might see a widened scar. They might have more fragile skin, so their skin might tear more easily. Some of the other things that we might see are things like hernias or pelvic floor prolapse and stretch marks.
Can a person have hypermobility without having all the comorbidities? Are there people who just are a little bit more flexible that might not have anything else?
There definitely are people who are hypermobile but don't have any other symptoms or problems. And it's important to distinguish. When a lot of people talk about hypermobility, oftentimes they don't distinguish between generalized joint hypermobility, localized joint hypermobility, and peripheral joint hypermobility. So say, for example, you're just bendy in your fingers and toes. That's called peripheral joint hypermobility. And that tends to be more often associated with vascular Ehlers-Danlos syndrome and some of the other genetic disorders. There's actually hundreds of disorders, by the way, hundreds of genetic disorders that are associated with joint hypermobility. Joint hypermobility is, of course, not always associated with a genetic disorder, though. So the other form of joint hypermobility is localized. So say, for example, that you're just hypermobile in your shoulders and nowhere else, then that would be considered localized joint hypermobility. And if you have hypermobility in, a wide range of places, then that would be considered generalized joint hypermobility. So it's important first to distinguish between those different types. People who have generalized joint hypermobility still may or may not, any of the types, may or may not have symptoms. So it is possible to have any of those three types and not have symptoms, or maybe the person doesn't have symptoms but will develop them in the future, or maybe they already have symptoms. So I believe that it is super important for all physicians, healthcare practitioners, providers to be aware of these conditions because of the contributing factor that they play such a significant role with chronic pain. And we know chronic pain is such a huge problem in our society. And the contributing factor of joint hypermobility is really very often missed. So although a person might not be having any problems, that doesn't mean that they won't develop any problems related to the joint hypermobility in the future.
When I was a kid, I was never a good runner, probably because I was way floppy and I always hated running. But then when I was 14 and got introduced to yoga, I was like such a natural. And it actually took me a long time and really, really good and attentive yoga teachers to help me back off from using my joints to really align and strengthen the muscles, tendons, and ligaments so that my alignment was appropriate, as opposed to just like, I can put my hands flat on the floor. I can, like sit up in bed, fold forward, and put my hands past my feet.
When we have an end range that goes past straight like that, like your arms bend backwards, and I don't know if your knees bend backwards, but lots of people who have, so those are two hinge joints that people often kind of go together, like in same ball and socket joints being your shoulders and your hips. So they're just kind of built differently. But so if people have hypermobile elbows, say for example, you're doing a yoga pose, it's easier to let your arm go into that hypermobile range. Correct. Because it requires less energy. It requires a lot more energy, whether they're knees or elbows. If you're weight bearing, it requires a lot more energy to hold it in quote unquote straight alignment. And if you happen to have just normal range of motion, then you don't have to put in that extra effort. But if you are hypermobile, it's really hard for two reasons. One, because it requires more energy to do that. And two, people who are hypermobile have decreased proprioception. So they have less ability to know where their body is in space without looking. And this is really important because oftentimes hypermobile people, they'll say, well, but no, I'm not hyperextending my arm or my knee or whatever. They can't tell unless they're looking in a mirror, and even then you have to really point it out to them, sometimes they can't feel where things are. And there's a variety of reasons why that's the case, or a variety of reasons why we think that's the case. But yeah, oftentimes people long before they have any problems, they just knew that they were flexible as a kid, or they were super good at dance. I'm obviously a former dancer. So in ballet, it was advantageous to be flexible, although I wasn't the most flexible one in my class, but it was advantageous. I'm hoping that by the work that I'm doing, the work that you're doing, that we can make more people aware of these things so that they can take the steps necessary to help prevent developing problems down the road, and giving them the tools so that they can develop that strength, like what you're talking about, like what you did for yoga. And also too, then as they go to their healthcare providers, as they are having problems, they won't have as long of a diagnostic odyssey as, a lot of other people have had with getting the psychological distress that happens when you're told, no, there's nothing wrong with you. You must be making this up.
One way that we could shorten that from both the practitioner as well as the patient perspective is to look at the Beighton scale. Can you talk a little bit about that Beighton scale as an initial screening tool?
Sure. And before I talk about the Beighton scale, I do want to just mention really quickly that there was a study, I believe it was published in 2019, looking at the people who were diagnosed in that longer time frame, like that, 25, 28 years versus 18 years, I think it was, something like that. And the people who had that longer time to diagnosis had a much higher incidence of severe pain. That's the other thing, is if we can catch people sooner, I really believe that that's the best way to help prevent chronic pain. And once pain becomes chronic, it's just so much more difficult to treat. So I feel like this is I believe it's actually an emergent health situation in this country and all around the world, actually, that it's not just the people who are suffering now, of which there are many, many, many of them, but it's the people who potentially could suffer in the future. We actually have the tools to help them now and to give them preventative measures that they can take. I think that's just so incredibly important. If we can prevent chronic pain, that's so much better than treating chronic pain. So to answer your question about the Beighton score, so this is the tricky thing. How do you come up with a measuring tool for generalized joint hypermobility? So there's a lot of different tools that are out there. There's one called the lower limb assessment score. There's one specific to the upper extremities. There's a whole bunch that are named after different people. The one that's most commonly used is called the Beighton score. And the Beighton score has been validated in the most research studies. However, it was never really intended for clinical use, and it's challenging because it's really biased towards the upper extremities. But real quick, what's the Beighton score? So you get 1 point for each of these maneuvers that you can do. So the first one is, can you touch your thumb to your forearm? And you get 1 point for each side you get 1 point for each side that you can do that on. And you can do that on both sides. Okay, and by the way, if people are following along and doing this test, do not hurt yourself. It's like, if this is hard to do, then don't push it, because I have, in trying to demonstrate to my rheumatologist that I could do this, I have exacerbated my wrist pain so I should mention that real quick. And then the next one is, can you bend back your fifth finger with a greater than 90-degree angle? We'll actually put their hand on the exam table. Oh, but look at how hypermobile your distal interphalangeal joint is. And then the next 2 points are for the elbows. So do the elbows hyperextend? You can eyeball. If it's way past, you can eyeball it for sure. If it's close, then you always should use it. A goniometer is one of those things that it's made out of plastic. It has like a round circle in the middle, and then it has 2 arms basically that allow you to measure the angle. There's a total of 9 points. That's 6 of them, and we haven't left the upper extremities yet. So that's the thing. It's biased towards the upper extremities. It doesn't include the shoulders and hips. It doesn't include anything along the spine. Okay, so then the next 2 points are for the knees. The knees are tested the exact same way as the elbows. Do they hyperextend by more than 10 degrees? So that's the next 2 points. And then the last point is something that almost virtually all dancers can do, and lots of non-dancers, of course, as well. But the last point is you put your feet together, and then you see, can you put your palms on the floor without bending your knees? So that's the 9th point, which, of course, like I said, for people who have trained to have flexible hamstrings, spine, etc., that makes that point kind of how valid is that? So the difficulty with the Beighton score is that it's quick and easy to do, so that's great, but yet it has all this validation in clinical studies. But at the same time that we know that joint hypermobility or joint mobility goes down as we age, The Beighton score will go down as we age, but that's usually when you have the most symptoms. In 2003, Drs. Hakim and Graham published something called the 5-point questionnaire. And this is really great because it takes into account some of the elements of the Beighton score, but also historical information. So when you're testing the Beighton score, you're not actually supposed to take into account if someone has had surgery, for example. Well, if you've had surgery on an elbow, that's of course going to affect the range of motion. But when you look at the 5-point questionnaire, the first 2 questions are part of the Beighton score, but they ask, can you now or could you ever touch your thumb to your forearm? Could you now or could you? And then the other questions have to do with when you were younger, did you amuse your friends with, like party tricks? Do you consider yourself double jointed? That's what the 5-point questionnaire is, questions like that. And I really like that 5-point questionnaire. I think it's a better tool. And if you answer 2 or more yeses on those 5 questions, then it has something like approximately 90% sensitivity and specificity for generalized joint hypermobility. So the important thing is oftentimes people get that mixed up and they think that those are tests for EDS, Ehlers-Danlos syndromes, and they're not. Those tests are to determine if you have generalized joint hypermobility, which is one of the criteria for hypermobile EDS, which is the one form of EDS that does not have a genetic marker. Therefore, it's a clinical diagnosis. And that's why these clinical criteria are so important, because it's a clinical diagnosis. There's no lab test for it.
When we do lab testing, like genetics testing for EDS, and we do that at our clinic and you do that at yours, what we're looking for are the other 12 types of Ehler-Danlos.
Right. And actually, since they developed the criteria, the new classification in 2017, there's now one more type. So now there's a total of 14, by far the most common type. We do not have a molecular marker for that yet. So yes, the other 13 types, though, can be tested by genetics.
Seems like hypermobility spectrum disorders have a lot in common with hypermobile EDS. And then what we know from the other 13 types of EDS, those have kind of we can look at these genetic markers. So why is hypermobile EDS part of an EDS more than a part of a hypermobility? Like, why is hypermobility not its own thing as opposed to separate from EDS?
Okay, so let me see if I can answer this in a fairly succinct way, because we could talk about just this specifically for hours. So I think if we think first about joint hypermobility and the fact that something that is correlated with, like I said, hundreds of different genetic disorders. Amongst those genetic disorders, we know that the Ehlers-Danlos syndromes are by far most common. And amongst the Ehlers-Danlos syndromes, which are, we just talked about how many of those there were, the classical type and the vascular type come second after the hypermobile type is the most common. What they did in 2017 was they said, we don't know what the molecular marker is of hypermobile EDS. We believe that it's going to be something similar to these others. That's why we're keeping it, with the EDS diagnosis. But we really need to figure this out so that we can have a genetic test for this. So this is what we're going to do. We're going to make the basket for hypermobile EDS super, super small, so that way that will facilitate our finding the genetic marker, or markers, I should say, because we feel quite confident now that there are multiple markers that have to do with the building of the extracellular matrix that will come up once we figure out where the defect or defects lie in hypermobile EDS. And then what they did was they said, for the people who no longer meet that criteria, fit in that basket, we're going to create a new label called Hypermobility Spectrum Disorder. And it actually technically is Hypermobility Spectrum Disorders, because you can have the localized type, you can have the peripheral type, or the generalized type. So when they came up with that new term in 2017, that was the idea, was that, if you no longer meet the criteria of EDS, hypermobile EDS, now you can have this diagnosis of HSD, so you're not just kind of left with no diagnosis. Well, what happened was that left a lot of people very, very upset, because it was perceived that the hypermobility spectrum disorder is like a lesser than diagnosis. And I will say that I tell patients, by the way, this is a fantastic question, actually, because it gets to the heart of what's so upsetting for people. So I will tell people that this is not a lesser than diagnosis, hypermobility spectrum disorder. But at the same time, I know that my colleagues who are not as focused on this as I am, to them, it is a lesser diagnosis. So I understand patients being super upset when, say a colleague of mine who's practicing general surgery or something, and they have a patient come in and they're going to be doing surgery on them, and it says that they have Ehlers-Danlos syndrome. I feel like that person knows, oh, that has to do with connective tissue and healing, and this might be relevant. Maybe I should think about this more or ask somebody what I should do about this. Should I plan the surgery better, differently, leave the stitches in longer, etc., or at least ask the person more questions. But if it says hypermobility spectrum disorder, I feel like that just doesn't have the gravitas that EDS has. So a lot of people are really, really upset, and I think with good reason. And I think the other super important thing to know about this is that just like there's a lot of other alternative scoring systems for joint hypermobility to the Beighton score, there's a lot of alternative clinical classification systems that are different than the 2017 criteria that were set forth by the International Consortium. And every paper that I've read on these, they go through and they explain like why they chose this, why they chose this, why. And I'm sure that the International Consortium had great reasons why they chose the things that they chose. But in the one-page form that they give us to fill out, they don't explain why. They don't have references there that explain why. Like, for example, piezogenic papules, which are those bumps that people can get on their heels. There are some studies that show that painful piezogenic papules greater than whatever the size was, I think it was a couple millimeters in size, are potentially correlated with connective tissue disorders. I believe there's like literally 1 or 2 papers on that. But that made it onto the clinical criteria for Ehlers-Danlos syndromes, and it didn't even say that they had to be painful or of a certain size. So there's a lot of contention around this issue about the criteria. There's a paper that was published by a group in Toronto. I believe it's called Good Hope, the clinic there. And they looked at people that had EDS, hypermobile EDS diagnoses, and they reclassified them according to the 2017 criteria. And according to the 2017 criteria, only 16% of those people still met the criteria for EDS. And yet they had all kinds of symptoms. It's not just that these people didn't have a lot of other things going on. They just had a lot of things going on that are not accounted for in the 2017 criteria. There's another paper that I came across recently where they also looked at, I believe that they started out looking at something like 100 different clinical features. This is work by Hamanet et al. In France. Mm-hmm. And some of the things that they came up with as they came up with a list of ultimately 12 things. If you have 5 or more of those, it was, I believe, the specificity and sensitivity was around 99%. And they have a number of things on this list that show up nowhere in the 2017 criteria. For example, fatigue, really significant fatigue. That doesn't show up anywhere on the 2017 criteria, but this is on their list. Sensitivity to sounds, constipation, gastroesophageal reflux, bruising. These are things that are on Hamanet et al. On their list, but they're not on the 2017 criteria list. So I think it's just important to realize that this is really a moving target. So people should stay tuned, number one. And number two, try not to get frustrated. Try to get as many resources as you can. And I highly recommend everyone get the book Disjointed. I don't get any royalties from the sale of the book, but it is loaded with information, and take it to your healthcare professionals and see if they would be willing to read it, or ask them, tell them you have this book and would they be willing to take a look, because there's pretty much something in there for everyone.
So what I'm taking, this is a moving target, but while this target about diagnostic criteria and official labeling happens, patients continue to develop pain and continue to not necessarily be treated as they need to be treated to prevent future pain. So our emphasis really needs to be, again, back onto the patient experience, regardless of which criteria they might meet or not meet. We need to recognize if patients are coming with a whole slew of symptoms that cross silos, and by silos, I mean the silo of cardiology, the silo of neurology, the silo of gastroenterology. When you have symptoms that cross systems through your body, then hypermobility spectrum disorders or hypermobile EDS or EDS should be on your radar.
And I think most of us don't realize the weight that our words carry. And if we don't validate the patient, and if we don't trust them and we don't believe them, are there patients that sometimes don't tell the truth? Yes, of course. Anyone who's practiced for a while knows that. But why are we mistrusting people for no good reason? Unless they've shown you a reason why you shouldn't believe them, then you should believe them. And so your point about silos is an excellent one too, because there's a saying, if you can't connect the issues, think connective tissues. And I believe that this was first said by Dr. Heidi Collins. And it's a fabulous way of remembering that if there's a bunch of different things going on and you can't connect them, Dr. Lawrence Afrin wrote the book Occam's Razor. it's such a good way to think, how likely is it that this person has like 20 different things going on, or that there's one unifying factor that is what presents in this way of, manifestations in multiple different bodily systems.
Your specialty, kind of what we had set out to talk about today, was specifically is discussing pain. And I do actually just want to briefly mention that in the Disjointed book, you do have a chapter about perioperative care as well. So if you may have some hypermobility, if you've checked this bite and score along as we've been talking about it, or whether you've had a diagnosis of that or not, that you should check out Dr. Bluestein's chapter on perioperative care if you're having a surgery. And one thing that we know about what we call fondly, compassionately, the pentad patients, the pentad being the conditions of dysautonomia, gastroparesis or GI symptoms, mast cell activation, autoimmune, and hypermobility or EDS. But if you are a pentad patient, if you struggle with those things, then you should be checking out that perioperative to prepare yourself, and then perhaps discuss that with your surgeon so that you can have a better chance of healing well.
Yeah, healing well. And I think the other thing that I really wanted to stress from that chapter, and I'll take the opportunity since you brought it up to mention it now, your average person doesn't necessarily know that you might be repositioned after you've been put to sleep. So say, for example, you're having spine surgery and they're approaching it from the back. After you go to sleep, they're going to put you to sleep while you're on your back, supine, and then we put the breathing tube in, and then we roll you onto your stomach. Mm-hmm. If you have a lot of joint laxity, it's important to distinguish between joint hypermobility, which is range of motion, and joint laxity or instability, which is where the joint comes out of alignment. Those are two different things. If you have a lot of problems with joint laxity, and maybe you have dislocations, subluxations, etc., then you could have a joint that dislocates or becomes subluxed when we move you from one position to the other under anesthesia. So there's a couple key points from that chapter. That's one. You want to make sure that you ask your surgeon, what position will I be in for the surgery? And number two, if you have any neck issues, jaw issues related to your airway, which basically starts at your nose or your mouth and goes, into your kind of mid-chest level where the endotracheal tube ends. If they're going to be putting in a breathing tube, it's very important to point these things out because of the fact that you may run into more issues with neck pain afterwards, or some serious complication potentially if your care team is not aware of this. So I'm glad you brought up that chapter, because I think that as an anesthesiologist, that's one of my passions, is to help my colleagues become more aware of this, because when I was practicing in the OR, that was a different phase of my own career. Now I'm on, I think, part C or so, or D maybe, and they don't have time to read up on, every condition that's out there, but they are seeing these people, they are taking care of them. And I bet if we could go back and look and see people that have neuropathy after surgery or have other complications with joints and things like that, I bet you that we would find that more of them that are having those problems were hypermobile.
I think of anesthesia as being heavy users of B vitamins, so that if people are nutritionally deficient before, or if digestion is not optimal before, maybe there's not enough hydrochloric acid, we tend to get hypochlorhydric as we age, so we may even uptake B12 less through the GI tract. So if that is low, or if we have MTHFR or other SNP mutations or variations that maybe aren't activating our B12, I think of anesthesia as being a heavy load on those aspects of metabolism. But now this has given me another thing to think about in terms of going into a planned surgery. And we know that a lot of patients who are pentad patients end up struggling with surgeries, because as tissues become more lax, like for instance, incontinence in aging women, then the typical treatment ends up being often surgical. And so sometimes I've had many a mast cell patient who I've seen in their 50s or 60s say to me, oh my God, I think I've had between 5 and 12 unnecessary surgeries, because they have the surgery for something, the symptoms remain, no one can figure it out, and they say, well, it's not because, your tissues are incorrectly positioned, and then we find out later treating them with something like cromolyn or ketotifen or quercetin or some of these other mast cell treatments can then reverse the symptoms that they had, whereas the surgery was totally ineffective.
Yes, I'm so glad that you brought that up. I personally have had several surgeries that I would like to go back and not have. I do believe that this is a huge, huge problem. We don't heal the way that other people do. If we do the surgery without addressing the underlying problem, then it's not the right fix, right? So if we go in with the wrong diagnosis, or, we think that it's exactly like you said, we think that it's one thing, but it's actually something else. So I'm really glad that you brought that up, because the other message that I hope people will listen to is that please, please, please contact your legislatures and tell them that you want reimbursement for non-surgical, non-operative, non-procedural, but complex type care. We would like to be able to take insurance, but we can't because insurance doesn't value what we do. Insurance companies value large volumes of patients seen in a day and surgeries and procedures. And I'm really glad that you brought that up because that's really expensive to the healthcare system, having all those surgeries. You think of if you could take the money from one of those surgeries and instead apply it to acupuncture, physical therapy, occupational therapy, Ayurvedic medicine, seeing a nutritionist, and all. Think how far that would go. You could actually pay for a lot of things, and that would be more addressing the root cause of the problem rather than that surgery that often leads to more surgery, and ultimately the person realizes that that was not the right path in the first place. So that is definitely one of my soapboxes.
In the movie Escape Fire that came out a couple years ago talking about the healthcare system, there's a cardiologist featured in there who talked about, if I put a stent in a heart, I get paid $10,000 for about an hour of my time. And if I do an hour of nutritional counseling, I get paid about $100 for an hour of my time. And that, just looking at where value is placed in the healthcare system is kind of just astounding.
And it is interesting. That's great that he made that comparison because while I do think that we need to compensate people for the skill set that they went many, many more years to school for and have a super high level of stress, like neurosurgeons, for example,
right.
I certainly don't want to do brain surgery. So we do need to make sure that we are valuing the skill set that this person acquired and the amount of debt that they went into while they were not, earning a living. But at the same time, we need to make sure that we're not weighing things so heavily, tipping the scale so heavily in that direction. I think it's really, really important to look at all of that. And when I first learned about functional medicine, I remember sitting there with my mouth open going, yes, 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 this is,
yes.
Again, if we can, prevention, right? If you can spend so much less money on prevention than on treatment. And could we prevent all those stents? But of course, it's harder to study something that didn't happen. If you prevented it, then it's harder to study it and it's less sexy,
Right.
So we have a lot of challenges that we're up against.
In talking about preventing pain versus treating pain, there were some things I really wanted to make sure we got to, which is the 3 types of pain. Could you go through those? Nociceptive, neuropathic, and nociplastic pain?
So there are 3 main types of pain. So nociceptive pain is basically pain that comes from actual or potential tissue damage. So that's kind of when most people think of pain, they think of that actually. So that's in the case of hypermobility disorders, this is the pain that you get from like a subluxation or a dislocation or the pain that you get from an injury or something like that. It tends to be, more of a direct, this happens in the tissues and then you feel the pain in your nervous system. Then the neuropathic pain, the pain is actually in the nervous system. So the best example that I like to use for this is if you think about like diabetic neuropathy, or an even better example is when people have post-amputation pain. And again, when I was an anesthesiologist practicing in the OR, I knew that people who had amputations had an extremely high incidence of post-amputation pain, like 90+%, and that it was incredibly difficult to treat. But I didn't understand it at a level like I do now. And it makes sense if you think about it, that the pain must be in the nervous system, because how can the leg hurt that's no longer there? Right. And it also tells you that you really need to be targeting the nervous system because you can't target that tissue that no longer exists. Neuropathic pain is pain that's in the nervous system, and the nociplastic pain is related to dysfunction of the way the nervous system processes pain signals. So it was so interesting. Before I opened my clinic, I thought, okay, I bet I'm going to see a fair number of people that have nociplastic pain with EDS and related disorders, and I would say it's 100%. And even young people. Pain begets pain. Once you're in pain, your body generates mediators and things that make it so that you become more sensitized to pain. And in an acute setting, that's helpful because it helps protect you from future pain. So say, for example, you burn your finger and then the sensitivity to that part of your body is ramped up so that you don't then go and burn it again. But in a chronic situation, this is when it really becomes dysfunctional. And this is where the more we can prevent pain, the better off we're going to be, rather than just playing whack-a-mole and, treating this and this. And that's where I try to really get a sense when I'm seeing a patient for the first time, do they have fairly localized pain? Is it in one area of their body and that's really the one that stands out? Or are they having so much pain all over that we really have to focus all of our efforts on the nervous system and the processing of the pain signals? Because it's like the nervous system is going haywire, and the threshold at which you're supposed to say, ouch, has become much, much lower. So we know people will know what these things are. They might not know the words for them, but there's things called allodynia and hyperalgesia, and those indicate that you have sensitization of the nervous system. And allodynia is when things that are not normally painful are painful. So for example, sheets touching your feet. And hyperalgesia is when things that are normally painful are more painful. So for example, you're getting your blood pressure taken, and instead of it feeling, a little bit uncomfortable, it's like excruciatingly painful. So those are important indicators.
When in the time course of having a nociceptive or neuropathic pain, does it become a nociplastic pain? And when does it become a nociplastic pain?
It depends on what the insult was or what the insults are. The more insults you have, the more likely you are to develop nociplastic pain. And the other ways that we know that you have nociplastic pain is if you have other diagnoses that suggest nociplastic pain, like irritable bowel syndrome, migraine headache disorder. If you maybe you already have a diagnosis of fibromyalgia, which is kind of the classic central sensitization syndrome. Nobody knows exactly when that flips from the nociplastic or neuropathic to the nociplastic, but on average, around 3 to 6 months or so is when we normally consider pain to be, acute pain is like less than 6 weeks, subacute pain is 6 weeks to 3 months, and then greater than 3 months is kind of considered chronic pain. That's not to say that they could still have a fairly acute cause more than 3 months out, but that's just kind of a time frame that we use for defining different pain syndromes. So we really want to think about, what else are we seeing in this person? And it's a really, really common problem in the EDS population.
There's one quote in your book that I really liked about, or one thing I got really curious about, was neuroimaging studies in patients with central sensitization show changes in the pain processing regions of the brain. Neurochemical imbalances are accompanied by altered resting brain connectivity between pro-nociceptive and anti-nociceptive areas that promote and dampen pain respectively. So what are those neuroimaging studies and what looks different? What does that mean about brain connectivity?
So people are familiar with MRI, right? Magnetic resonance imaging, but they also can do functional MRI. And we've learned a lot with more advanced technology and the ability to do functional MRI and also SPECT scans where they can actually look at uptake in different parts of the brain. So there are parts of our brain that talk to each other that either amplify pain signals or dampen them. So the fascinating thing about central sensitization or nociplastic pain, they're not exactly identical, but they're basically the same concept. The fascinating thing about that is that it happens on multiple different levels. So we know it happens at the level of the brain. Normally you get this top-down like inhibition of pain signals that becomes less, and at the level of like the spinal cord and the peripheral nervous system, we also have changes with things like substance P and inflammatory cytokines, and neuroinflammation is accelerated. So it actually is something that appears to happen on multiple different levels.
How do we, once a person has been sensitized centrally for nociplastic pain, how do we unwind that?
I think the biggest challenge with a lot of people that are in chronic pain, and I made the same mistake myself when I was having a lot of issues, is they're looking for a thing that's going to make them better. And they think that there is a single thing out there that's going to fix everything. And I believe that it requires a multifaceted approach, that it requires working on movement and renormalizing movement and reintroducing gentle stretch to the fascia in the body and the tissues starting to move again. Because sometimes people with connective tissue disorders, they're in so much pain that they end up moving less and less and less, and then that just makes them have more and more and more pain. So unwinding all of this takes time, I guess, is the first thing that I would say. So it requires a lot of patience, and it requires an open mindset. We know that expectations matter a lot. So if you go into it thinking none of this is going to work, none of it will work. They call that the nocebo effect, right? We know about the placebo effect. So the nocebo effect is where you think it's not going to work, and guess what? It's not. So that's really important. And so we can, though, unwind this, at least to a certain extent. And the way I look at it is that we can't remove all of pain, but we can at least alleviate suffering. So I look at it as suffering equals pain plus fear. And if we can work on that fear component, we can help lower our suffering. And even if we have pain still, we can get it to go into the background of our mind and not have it be pain, 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 like pain brain, I call it. If our brain is on fire with pain and we can think of nothing else. And that's what ends up happening is we end up getting, kind of obsessed with it. And that's all we think about. And that's all we talk about. And our lives become revolved around that. So it's gradually introducing joyful activities, things that we used to do that we really loved, but we've completely given up because of this pain problem. Addressing things from a medical standpoint too. And oftentimes that involves prescriptions, and changing the diet can make a very, very big difference. A lot of our foods are very pro-inflammatory. So if we change the diet to a less inflammatory diet, and a lot of people are really not getting much in the way of nutrients in their diet. If they're eating a heavily processed diet, if they're eating the standard American diet, right, the SAD diet, then they're getting a lot of pro-inflammatory things, and they're missing the nutrients that are critically necessary for our bodies. You mentioned the B vitamins earlier. I think we often forget that our food is there to nourish us, right? And we need that in order for our body to function properly. The approach that I take is like multifaceted. It involves addressing the psychosocial factors. It involves addressing the movement aspects. It involves improving sleep. Sleep is a huge problem for a lot of people, and it becomes cyclical in nature. So, you have pain, you can't sleep, and then that makes your pain worse, and so it makes your sleep worse, and it just kind of feeds on itself. So it's unraveling that. And, there are some medications that I will prescribe that can help with this. There are some supplements. One really important thing to know is that opioids actually make this worse in many, many cases. So I believe that opioids are, especially for chronic non-cancer pain, are really not the right hammer for that nail in the EDS population in particular, for a couple of reasons. One, because of opioid-induced hyperalgesia. Again, hyperalgesia means when you're more sensitive to pain, okay? And two, because of course, the usual problems that we have with opioids with, dependence, tolerance. You have to keep escalating the dose in order to get the same effect. And then the third thing being that they can activate mast cell degranulation. So opioids can cause a lot of problems for people with EDS. Now, that doesn't mean to say that they shouldn't use them if they really, really need to in the short term, after surgery, after an injury, something like that. But I think even then, if you have other alternatives, if you can work with a doctor that does prescribe other alternatives, then, again, reserve those things for, kind of the last resort. That's the approach that I take anyway.
In your book chapter, I'm just going to read these off so our listeners kind of have an extensive list. I loved how you divided physical strategies by active and passive, the things that happen to people or you can have done to you versus the things that you go after. But I'm just going to read this list out: acupuncture, massage, myofascial release, craniosacral therapy, Pilates, Alexander technique, Feldenkrais, reflexology, water therapy, sauna, sleep, low-level laser therapy, iontophoresis, hyperbaric oxygen therapy, DNRS, which is dynamic neural retraining system, apps like Calm, Breathe, Headspace, meditation apps, vagal stimulation, electroceuticals like the Alpha Stim, interventional treatments like diagnostic nerve blocks, steroid injections, spinal cord stimulators, intrathecal pain pumps, and regenerational techniques like PRP, which is plasma-rich protein, stem cells, or prolotherapy. So all of those, at the risk of not having enough time to talk about some of the other stuff, just know that there are lots of ways to approach this. And that's in addition, of course, to lifestyle, environment, psychosocial, mental health, and diet.
Can I tell a quick DNRS story?
Yeah, please do.
I had a patient who came to me. She was very, very sick. She couldn't be upright at all. Heart rate was extremely high. And she came to me only able to tolerate 2 foods. And this was several years ago now, and she lives several hours from me. So I saw her a handful of times, and then I kind of had lost touch with her a little bit. And she called me the other day to just give me an update as to how she was doing. And I almost fell on the floor when I heard her message. She said, "I'm dancing again. I can eat whatever I want." And I was like, what? I was so excited. So I called her back and I said, "So tell me what, because last I had talked to her, she was doing okay, but she was considering going to New York for neurosurgery and, had a lot of problems. She was very, very sick." had terrible mast cell activation syndrome, lab proven. Like, you know how we can never get the positive labs on anyone, right?
Uh-huh,
Hers
uh-huh.
were all positive.
Wow,
In
that's
fact, in fact,
impressive.
yeah. In fact, she is also a patient of Dr. Afrin's,
Hmm.
and she said it's okay to tell her story. By the way, I'm not going to share her name, of course. But anyway, so I said, "Well, what do you attribute that to?" And she said, "Well, of course, we worked. She and I worked on a number of different changes, medications, and things like that." But she said probably the biggest factor was DNRS. And she had tried a different system prior to the DNRS. And she said, I trained on the DNRS like I was an Olympic athlete. Hearing her story, I realized, not everyone has that luxury. She has supportive parents that, she didn't have to work to keep a roof over her head. So she was very fortunate in that regard and recognizes that. But she is so incredibly dedicated. She said some days she meditated and did these mental exercises for like 4 hours a day every
Yeah.
day. And she attributes most of her recovery to this. And I had seen about DNRS before. I've talked to people about it, but she's the first patient that I've had that had this incredible success story with it. And she gets nothing for saying any of this. I get nothing for saying any of this. I've never met anyone who would run the company or anything. But I think that's just to show that a lot of these tools really can make a difference if you have an open mind. And again, you have to have the resources. I understand not everyone has the same resources. That's really, really challenging. And I know you're super passionate about that, about
Hmm.
the cultural differences and accessibility to some of these different things can make it,
Hmm.
really, really challenging for a lot of people. But there are people who can access these types of things and they don't for various different reasons. And I would just encourage people to please keep an open mind and go into anything that you try with the attitude of training like an Olympic athlete
Yeah.
and tell yourself this is going to work, because it's more likely to work if you tell yourself that.
I often will tell patients that, when we give you a tiny little pill to swallow, those molecules impact your molecules, but it's only so much stimulation to the molecules in your system, to the receptors in your system. But when you shift your thinking, when you are able to shift even for a minute or two, your assumptions about the world. And it might be that those assumptions shift after an hour of meditation or breath work, or after one good night of sleep in which you push everything else away and you are able to actually sleep deeply. And sometimes we do give medications to help people sleep or to help people do this. Those shifts that happen will affect all levels of your psychoneuroimmunoendocrine systems. And so that cascade will reach so many more receptors and so many more systems than any pill ever will, which is why we try to use that. I think we can get lost. The flip side, however, is that we can get lost. Like if you're still sick, it's probably your fault because you haven't shifted your mind. And I want to be really clear that that is not the case. We come by our thinking because it's the best thinking that we could do at the moment. And we did a great job. Like I think we have to know that people come at their lives trying to get what they need, trying for longevity, trying for survival, and that the patterns that are set early often do persist over time. And even when they're no longer helpful, like if I don't want anyone to love me, then I'll never be disappointed. So we come by these things honestly. We come by our thinking honestly because it was what kept us alive at what point, but we can use the potential of our mind to move ourselves forward. So I absolutely agree. This we were, kind of, sometimes people label it like your attitude is your latitude. And there are, especially in our system today, it's after 2 weeks after the video of George Floyd being killed by the Minnesota police. There are ways in which we suffer under oppressions which have nothing to do with us or our family system. There are ways in which the social systems around us do prevent us from doing things that we are here on earth to do. And so continuing to work, all of us in partnership, in collaboration with the ways that we can make change so that we get all of our talent. So all the talent that we have kept down can flourish and our society can benefit from everybody reaching their full potential. That is really what we're after. So one by one, we work. There are some really interesting medications. And actually in that list that I mentioned before, what I didn't mention was all the different supplements and vitamins and minerals and detoxification supports. So I also want to skip those for now, because I think you've got some really good insight into some of the medications. And the ones specifically that I'm curious if you might discuss include muscle relaxants, because, relaxing a muscle is the flip side of the coin of laxity. So if you could talk about that. And then I'm also a little bit curious about NMDA receptor antagonist, ketamine or memantine. And then let's just start there for now.
So muscle relaxants tend to be fairly popular, I think, amongst primary care providers and certain types of specialists for treating pain. And I definitely have patients that, come to me, they've been prescribed muscle relaxants from other providers, and baclofen tends to be a really, really popular one. And I usually ask them, is it working? Well, they probably aren't coming to see me if it's working. So I know I'm probably going to get the answer no to that one, in which case I encourage them to stop it, because we don't want to, a lot of these are sedating. So we don't want any, people often have brain fog from the dysautonomia, and they have fatigue. And so we don't need to make them any more sedated than they already are. We want to make their muscles stronger, not weaker. So we also want to encourage, muscle activation. And so I don't think that muscle relaxants in general tend to be that helpful. I think, again, everything is highly individualized. So if someone says, gosh, that is really working for me, that's really helping me a lot, then, keeping them on it. But at the same time, it seems like more often than not, it's something that's prescribed for people and it doesn't help. If you do consider in that same category of muscle relaxants, benzodiazepines. So benzodiazepines are things like Valium or diazepam. There's things like lorazepam or Ativan, Xanax. And these drugs are a little bit tricky because they can be habit forming. So we have to be very careful. But at the same time, they can actually stabilize mast cells. And they can help with sleep. And for some patients with mast cell activation syndromes and sleep disorder, small doses, very, very small doses can be beneficial. So it's definitely not the first thing that I go to by any means, but there are situations in which it might be appropriate to use those drugs. And in terms of the NMDA antagonists, so these are super important because they can help to reverse some of that central sensitization that we talked about. The ones that I think of that I tend to use most commonly are magnesium, actually, as an NMDA antagonist. We know that a lot of people are deficient in magnesium, right? So magnesium is a supplement that I prescribe quite frequently and find that it helps with pain, it helps with sleep, it helps with mood, and it's such an important thing in the body. And most people cannot get, large percentage of people, I should say, cannot get enough through their diet. So, and depends on the type of magnesium salt that you prescribe, but you can also treat their constipation with that. And also there are certain ones that cross the blood-brain barrier better than others. So you can also sometimes improve brain fog with that as well. So magnesium is one thing that I prescribe quite frequently. And then the other thing that I prescribe quite frequently for this is ketamine. And ketamine is a controlled substance. Ketamine is, a lot of people might have heard of ketamine clinics where they're actually administering ketamine by intravenous infusion. In those settings, it can be very effective. Actually, the indications for ketamine infusion include substance use disorder, PTSD or post-traumatic stress disorder, anxiety, depression, and chronic pain. So those are at least 5 of the number of indications for ketamine infusion. Ketamine infusions, though, are like anything, not without risk, without, definite risk and cost. People don't understand, I think, often that the drug itself is cheap, but you need to have a certain level of monitoring. You're basically giving an anesthetic in a clinic setting. So you need to have a certain level of monitoring that when you're, treating people with these therapies. And you can also do this by injection. So that's something else that I've done is ketamine trigger point injections. And I've had some really, really good success with that.
And you use it trigger point, so not necessarily as an IM into a larger muscle for systemic use, but local use. Which trigger points do you use it locally for?
So I usually ask people, what are your greatest areas of pain, and go after those. And I don't think I've had any patient yet where I thought, let's consider this as a therapeutic option. And then when I go to examine them and try to find some trigger points where I can't find lots of trigger points, and I keep palpating around until I find the most painful areas for that person. And then I calculate the dose based on a whole bunch of different factors: their age, are they on ketamine already, or are they naive to ketamine? Did I do the procedure on them before, and what was the result from whatever dose it was that I used the last time, and all those kind of things. And then I mix it with lidocaine usually, and then I'll do these injections, and I usually, I'll take whatever the total dose was that I decided that I'm going to do, and I divide it into usually between 3 to 6 injections, but that's usually only maybe in a couple of muscle bodies. So it'll be, usually they can be in one position for the procedure. And I've had people say that for 6 weeks, they had no pain after that. Is it pain-free doing the procedure? Definitely not. But it works very, very quickly. I mean, within a matter of minutes, they go from their pain being 10 out of 10. I think most every instance to being 0 out of 10. And the people who didn't do well are the ones who, then go home and say, oh, I'm not having any pain. I think I'm going to go do all the things that I wanted to do before. And, we still have to be mindful of the fact that our muscles are used to a certain level of activity, and we don't want to change the load, our muscles and our tendons and our ligaments. If we change the load really quickly, our body can't compensate for that.
Yeah.
And it's in the rest phase that our body gets stronger, right? So we need to make sure we're increasing the dose of exercise really gradually. So that's why I do ketamine trigger point injections. And that also, by the way, does require a certain level of monitoring, and there are risks, obviously, like with anything. And then I also do prescribe ketamine, most commonly by something called ketamine troche. And that's something that you have to get from a compounding pharmacy that can be quite successful for pain as well. And you can also get it as a nasal spray. Those are the main ways that I've administered or prescribed ketamine.
How commonly do you use memantine for pain? We use that a lot in our neurology clinic for cognitive decline, for traumatic brain injury, so for post-TBI or post-concussion syndromes,
Sure.
Or autism. So it does help with glutamate in the brain. It helps decrease excitability and excitotoxicity. So if the brain is really fizzly, it can be something that can help calm that down. So we do use memantine. And it's kind of like, if you have somebody who's constantly poking on your shoulder, it's really hard to focus to do anything. If you're trying to take an SAT test and someone is yelling in your ear, hey, the house is on fire, you're not going to score well on that test. And that feels like the life of a person with chronic pain.
People who have EDS or hypermobility spectrum disorders, a higher incidence of dysautonomia, and those people often have brain fog. There's also a higher incidence of ADHD. It can be a real catch-22 because you have ADHD and you have chronic pain and you have lots of reasons for having those challenges.
Right. Yeah. Right. How about oxytocin? How commonly do you prescribe that?
I prescribe that fairly commonly. I've had really good results with some people. I've had patients who have had a lot of, I'm thinking of one person in particular who had a lot of emergency room visits, and put her on oxytocin, and between her first and second visit, she had no emergency room visits, and said, oh my gosh, where has this been all my life? It helped her sleep, it helped with her pain, and I feel like with both of those drugs, it's hit or miss. There are some people that say, oh my gosh, this is amazing and I love it and it really helps. And there's other people that say, it didn't do anything for me. And so it's, kind of either way. Oxytocin is a hormone. And they recently, I think it was on December 1st of 2019, where the federal rules changed for compounding pharmacies. And they really raised the bar in terms of what pharmacies needed to do in order to prescribe hormones. And so a lot of the pharmacies that people were using for their oxytocin are no longer able to prescribe that. So that can be one of the barriers to, and actually I should mention, a lot of insurance companies do not cover compounded medications. So that is another thing for people that, these medications, they're not cheap. That can be challenging for people.
Yeah. Well, we are at our time. So although I feel like I could go on and on and on, I think we should probably close. And I am so grateful for you coming on the show. Are there any things that feel kind of unsaid or that you'd like to touch on or before we close?
I think the biggest thing that I really want to instill in people is a sense of hope. That when we feel hopeless, that doesn't help our chronic pain. That doesn't help our brain function. That doesn't help our sleep. So I think it's just so important for people to realize that there are not only treatments available, but I feel confident that things are going to improve. And there are people who are doing fantastic research in the lab that are investigating all kinds of molecules and looking into different therapeutic options for future treatments. So I think it's really important for people to be aware of that, and for all of us to try to be good ambassadors for EDS and related disorders, and really try to get our healthcare professionals, to work with us on our team and to approach them in a way to make it easier for them to do so. Like I said about bringing in the book, if you bring in the book and you say, here, I want you to read this book, it's 688 pages, they're going to look at you like you're crazy. But if you say, I've been reading this book and it's really interesting, and, I think there's some things in here that may apply to me. If I left it with you, would you be willing to take a look at any of it? I'd be happy to, pick it up in a month or whatever. Again, just oftentimes biggest allies are going to be people that we wouldn't necessarily expect. And so I think it's important to just, keep that in mind when we're interacting with any of our healthcare professionals.
I have found the same. I have found that when patients bring me things like, this seems to represent me, if I take a look at what they think represents them, I may understand a little bit more of what they're going through by this other description. I have definitely struggled with some patients who come to me, they've done a lot of internet research, and they come to me and say, I had one patient who came to me and said, I have adrenal fatigue. And I said, how do you know? And he said, I had to stop riding my bike. And I said, why? And he said, I have adrenal fatigue. And I said, ride your bike again. And he came back and said, I feel much better. And sometimes when people will describe what is wrong, I can't get a sense of like what's happening. Like, what do they mean? I have brain inflammation. What does that mean? Oh, you have a headache and it feels like burning, and it feels like burning like a cap, like you're wearing a hat of fire on your head. So sometimes what I need is more, instead of bringing me what you think your diagnosis is, bring me a picture of what your symptoms feel like so I can get a sense of what's going on inside of you.
Yes, that's a wonderful way to explain that. Yes.
I really appreciate everything that you're saying. And what I've really appreciated about our conversation today is we've really run the gamut of nuts and bolts treatment, nuts and bolts diagnosis, why a diagnosis is like so damn difficult in hypermobility as well as Ehler-Danlos syndromes, all 14, currently 14 of them. If you go by this criteria versus that criteria, how this is a moving target, but how the patient's experience is really what we want to focus on. And I think we've mentioned just by some of our lists, like 20 different potential ways to approach this. And so there absolutely is a lot of hope. Our, nociplastic pain is representative of our neuroplasticity, the way in which at every moment our cells are dividing and changing and dividing and changing. And so sometimes I'll describe this as we're trying to fix the jet engine while it's in flight. There's no way you can land the body. I mean, you as an anesthesiologist probably did kind of land the body, take parts off and put parts back on. But outside an operative suite, we really need to fix the jet engine in flight. And that is possible to change our trajectory. So thank you so much for being on and sharing all of your incredible wisdom and experience with us.
You're very welcome.
You can find more about Dr. Bluestein at her website, hypermobilitymd.com. You can also find her podcast, her old one was Hypermobility Happy Hour. Her new one is Bendy Bodies. And so lots of information and ways to engage with her. And thank you for listening today. We've got lots of ways to continue this conversation through Facebook, Instagram, and Twitter. You can get more information from and about the Center for Healing Neurology at our website, centerforhealingneurology.com. Please be sure to share this show with any of your friends who you notice sitting with an elbow that's hyperextended beyond 10 degrees, even without your goniometer. And we welcome your rating and review wherever you get your podcasts. You can send topic requests to podcast@centerforhealingneurology.com. And just to finish our closing, we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together and are committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. Thank you for listening, and see you next time.
Partyfish Media. Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org or realrentduwamish.org.